Hello, my name is Joanna Kufel-Grabowska. I'm clinical oncologist and I work in the Medical University in Gdańsk. And I'm happy to tell you a few words about the breast cancer from this oncological point of view. Most of the breast cancer are localized in the upper external quadrant in the breast, like 55% of them. The most important diagnostic modalities is mammography, then ultrasound in younger women, and also MRI in some cases. But the basic of a diagnosis is always the biopsy and receiving the tissue for the further pathological diagnostic. And the best option for the biopsy is always the core biopsy, which takes so much sample as necessary for the pathological examination. We need pathology to have the examination of receptors that we use in everyday practice. It means estrogen receptor, progesterone receptor, and also HER2 receptor, which is located in the membrane of the breast cancer cell. We divide breast cancer in different subtypes. And luminal A, which means it is hormone receptor positive breast cancer with a low Ki67. Then we have luminal B, which is also hormone receptor positive breast cancer, but with the higher Ki67. Then we have triple negative, which means this is breast cancer which is negative for estrogen receptor, progesterone, and HER2. And we also have HER2 breast cancer, which can have estrogen receptor positive or negative. It means we have HER2 luminal and non-luminal breast cancer. In everyday practice, we use the TNM classification. T stands for the tumor, N for the lymph nodes, and M for the metastasis, which will show us the local regional involvement of the breast cancer. After the diagnosis, we start the therapy. It can be a surgery, it can be breast conserving surgery or the mastectomy, or it can be systemic therapy, which can be neoadjuvant, so pre-surgery, or post-surgery adjuvant therapy. And in different subtypes of the breast cancer, like for example in the triple negative and in HER2 positive breast cancer, we use neoadjuvant therapy to improve the prognosis of our patients. We use it in a small tumors bigger than 2 centimeters, or if there are any involved lymph nodes. Generally, neoadjuvant chemotherapy is used if we have very involved breast cancer, or in this special aggressive subtypes in the triple negative breast cancer, or in the HER2 positive breast cancer, or if the surgery is impossible, to reduce the tumor and to improve the prognosis of our patient. So once again, when we use neoadjuvant chemotherapy in inoperable breast cancer in stage 2B and stage 3, in stage 2A, in triple negative and in HER2 positive breast cancer, to de-escalate the surgery of radiotherapy. After neoadjuvant chemotherapy, we receive histopathological results. If all the cancer cells are killed because of the systemic therapy, there is the complete pathologic response, which improves the prognosis of our patient. If not all of the cancers are killed, then we have residual disease. The more the cancer lasts after the neoadjuvant systemic therapy, the prognosis of our patient is worse. And the pathologic complete response is different in the different subtypes, and the HER2 positive and triple negative breast cancer are the most aggressive subtypes, but also these are subtypes where we have the highest percentages of a complete pathologic response after the neoadjuvant systemic therapy. In hormonal receptor positive, and especially when we're with very low Ki67, the complete pathological response is only in 5% of all patients, in comparison to triple negative breast cancer, when pathologic complete response is diagnosed in about 40 to 60% of all our patients. As I also said, the more the residual disease, the prognosis of our patient is worse. That's why we have the special classification of residual cancer burden from 0 to 3. RCB3 means extensive residual disease. And in triple negative breast cancer, the overall or event-free survival after 5 and 10 years is very low in comparison to pathologic complete response, when there is 5 and 10 years, event-free survival is about 90%. Thank you for your attention.